All right, so let's talk a little bit about disaster recovery within the context of health insurance portability and accountability. One of the things that is important to understand as a healthcare facility is that you're required to have some kind of a disaster recovery plan. Um, the original Health Insurance Portability and Accountability Act was written into 42 U.S.C. Section 1320. And it granted the Secretary of Health and Human Services the authority to promulgate regulations that concern privacy and security. 2003, the security regulations were actually promulgated and went into effect in 2005. You can see those in 45 CFR sections 164. And they were around for a long time. In fact, they were published in the late 90s as a result of a working group of a number of security experts in the field. But the Bush administration, in the beginning of its administration, looked at those rules and said they're just too difficult for health insurers and healthcare companies to comply with. And they became a little bit looser and more watered down, and it took several more years before the secretary was ready to promulgate them. But what we ended up with is what we live with today under the security regulations. And they're really addressed to electronic protected health information. In particular, when we're talking about EPHI, you're talking about patients' names, their diagnosis, other health information about a patient that a patient would want to keep private. A lot of the information that would be stored in an electronic health record today. But EPHI, was some demographic info and some other things. So that, they had a kind of a data set in mind when they originally developed the security regulations. Now, they're broken into three sections. So when you're talking about EPHI, you have administrative, physical, and technical safeguards that are required under the regulations. Disaster recovery really falls within an administrative guideline. But there are technical components to DR, and they're just not described in detail in the security regulations. But if you're going to do DR, it's more than just writing a policy, which an administrative section is really about documentation policies. But at least to comply with HIPAA, you have to develop some kind of an emergency preparedness plan and have that in writing somewhere. So we'll talk about that a little bit. 164.308A7 is really where you would look for the contingency planning requirements. The language there is pretty general and it's pretty short. And I think as you look through the security regulations in general, you find that there's a fair amount of that, that there's not a specific technology that's required or a specific time frame for recovery or details that might actually be in a regulation in other places, or that really have to be in a meaningful emergency or contingency planning document. But there is a requirement that you have one, and you have a data backup plan. That's a part of the requirement for contingency planning. You have to have a way to recover data if you have a disaster or if you have a technical failure. And you need to be able to operate in emergency mode. And all that stuff is covered in 164.308A7. Now, disaster recovery itself is not defined within the regulations. And as I said earlier, partly that's because there's a sense that these regulations are technology neutral. They're based on broad principles rather than specific details about compliance and security. And they're also, the regulations themselves encourage organizations to engage in a cost-benefit analysis so that you implement a solution that's reasonable compared to the size and the threat to your electronic protected health information. And rather than have a one-size-fits-all sort of solution where you're required to implement a $4 million system, with a major disaster recovery solutions vendor, regardless of whether you see 10 patients a year or 10 million. That's not the goal of the security regulations. They're designed instead to really encourage a mechanism or a thought process for healthcare facilities that are covered entities to think about the various aspects of security and to implement things that make sense. So there's that kind of common sense that's built into the security regulations. Now, disaster itself, even though it's not defined, I think most organizations would look at hurricanes or floods or biological attack or an extended power outage. Those are typical disasters. Sometimes they're technical in nature. You can have an uncontrolled virus that attacks your network, destroys a lot of your computers. Those are things that you want to deal with. Disasters typically are environmental. They're usually things that can't be easily prevented, even though you can implement mitigations, but they're usually out of your control. That's the kind of the definition of a disaster most of the time. I think organizations should always participate in DR planning as part of a liability or facility insurance purchase. So when you buy an insurance policy for $5 million in case someone slips and falls in your facility, that a part of that thinking is that you also invest in disaster recovery and disaster recovery planning, so that if a bad thing happens beyond just a slip and fall, like a hurricane or a flood, then you have a plan in place, you have an approach in place in order to respond to that disaster, so that you can recover from it and be able to see patients again. Now, organizations that have information systems have more risk in general than those with paper, but you also have more options. If the building burns down and you have paper records, well, your paper records are gone unless you made a copy of every last one of those and put it somewhere else, which would be very expensive to do. If you have a computer system, you have options in order to take a copy of that digital information and put it somewhere safe so that you can return that data to production. And we'll talk about that a little bit in this presentation. Now, with a health record system, you have several options, I think, in an emergency. One of them is that you can just simply go back to paper documentation and operate in an emergency on paper. And for some facilities, for example, emergency rooms that are held to a different standard of care, or if you're recruited by, in a bioterrorism attack by the government, I don't think your patients are going to complain because you didn't look at the chart before you treated them for the anthrax outbreak. It's Cipro and move on to the next patient. So that may be perfectly appropriate, in some circumstances, to just simply document on paper. In other cases, you might want to be able to, have a down period and go back to your tape backups or other backup and recover your electronic health record database to a new system. You might be able to do that quickly enough. It may be that 8 hours is sufficient, compared to the actual expense of having a backup on tape. You might say that's perfectly appropriate, for your facility. If you don't operate 24/7, for example, that might be a solution for you. Now, in other cases, you might really want to look at a replicated backup of your database that's available in a warm or hot site facility, and then your downtime could be much more short, with that solution, so that you wouldn't have to have a lot of lost data or a lot of lost productivity. But again, that may be too expensive. It depends on your circumstances.